72-year-old male who is post-CABG 7 years back, and he has presented with non-STEMI. His angiogram shows a patent Lima 2 LAD with a 90% ISR in previously stented proximal SVG to OM graft. The size of the stent was 4.5 into 38. It was 6 months back, and the territory is viable. Now, the debate is to whether manage it with the drug-eluting balloon or manage it with stent. So let me invite first Dr. Sandeep Baswaraja, and he will be debating this with his side being on drug-eluting balloon. Dr. Sandeep, over to you.
Good morning, everyone. Can you all see my screen?
Yes, sir.
Okay, thank you. So, good morning, and for us, it's very early morning, 5 o'clock. So, thank you for the invite for this very prestigious meeting, and congratulations to Kamal and his team for putting this up, especially in this crisis time, which has affected everyone globally. So, I'm a cardiologist in Heartlands Hospital in Birmingham, and in this debate, I'll be participating on management of this patient who is a 72-year-old man with NSTEMI, with a background of CABG 7 years ago. He had angioplasty to vein graft up to his marginal 6 months ago, and now he has come back with a 90% restenosis, and the presentation is acute coronary syndrome. So, what are the management options? I think we've got 4 options here. Number 1, you could use a drug-coated balloon. Number 2, you can place another stent. Number 3, you can ignore the vein graft and treat the native vessel. And 4, you can go for a medical management. Because the patient has come with ACS, I think everyone agrees that medical management is not in the best interest for the patient. So how do we choose the other 3 options? Now, what's the best option? From my point of view, the best option is treating the native vessel. And why do I say this? What's the rationale? The rationale is that we need to know some facts about the vein grafts. Patency of the vein graft at 10 years is 50 to 60%. And even if they are patent, they tend to have degenerative changes. And once they start misbehaving, the long-term patency is very low. For example, this patient has restenosis, and the long-term patency of this vein graft is very, very low. So PCI to native vessel has a better outcome as compared to PCI to vein grafts. And this has been demonstrated in a paper by Emmanuel Brilakis from United States, where they have compared the native cohort for PCI in 73% of patients and compared with the vein graft. And the outcome at the long-term outcome for death, MI, or revascularization clearly shows that patients who had a PCI to the native vessel, that's in red, have done better compared to patients who had PCI to their vein grafts. And if I show you an example from our center, so this patient had a vein graft to the right coronary artery, and the native RCA is blocked. He comes in with acute ST elevation MI. So obviously, we first establish the flow in the vein graft, which is very degenerated, as you can see, very ectatic, and the lesion is here as a culprit. So we just balloon this, establish the flow, patient, the pain gets better, we give him GP2B3 inhibitors, and then he was sent home, and we brought him back 4 weeks later and opened the native RCA because we knew that the vein graft will not stay for long. So we basically gone with the Corsair and Gladius wire, antegrade knuckling. And then we came back retrograde through the vein graft. While it's open, we took the opportunity and went back with the Corsair and again a Gladius wire. We perform a reverse card by ballooning and connecting the two space. And you could see the retrograde wire going into the antegrade guide. Essentially, we had a very nice result where we opened the native RCA. So in my opinion, the first option should be treating the native vessel. It's better than vein graft. But let's say if you don't have that option, so either you can't open the artery because of anatomical problems, or if you don't have an expertise to open the native circumflex obviously here, then the next best option is to go for a DCB. And the reason why I say that is because we now have enough evidence in the literature. And more importantly, we have the ESC guidelines in 2014 and 2018, which have recommended DCB as the first line of treatment for patients with bare metal and drug-eluting restenosis. So we have a backup or backing up from the guidelines. What is the rationale? The rationale is to avoid another layer of metal, especially if there's a mechanical issue with the stent. Now, this trial by Gary Min's group, published a few years ago, shows that when they analyzed around 74 patients with restenosis in the vein graft, approximately 33% of them had a mechanical problem, that is under expansion or a fracture. So bearing this in mind, we have to have a very low threshold for using an intravascular ultrasound for management of restenosis before implanting a stent or a DCB. Again, if I show this case, this is of a native vessel, a patient who had a circumflex stent with a 3 millimeter drug-eluting stent a few years ago, comes back with the restenosis. Now, when I ask anyone in the audience or my previous experience in presenting this case, what would one do? I would say, I will take a 3.5 millimeter NC balloon and then I use a DCB. That's what the answer I get. But when you do an IVUS, what you see is a significant under-expansion of the or undersizing of the stent. It's a huge vessel. If you look at the distal reference diameter, it was 4.5, and proximally the vessel is 5 millimeter, and the stent which was placed was 3 millimeter. So what we did was we have now the confidence to take a bigger balloon because we have done an IVUS. So here we took a 4.5 millimeter NC balloon and approximately used a 5 millimeter NC balloon, and then we rechecked the IVUS. You could clearly see there's a significant improvement in the stent expansion after the IVUS and optimization with a higher or a larger NC balloon. Following this, we used a long magic touch, which is excellent sirolimus coated balloon, in fact, from India. And we had a great result. This was done almost 15 months ago, and patient is completely asymptomatic. If I had not done an IVUS, and if I had used a 3.5 millimeter or DCB, this patient would have come back with further restenosis. So intravascular imaging is very important, especially for restenotic lesions. Now, when would I go for another drug-eluting stent in this case? I would go for stent if I had a failed case of DCB. So by using both paclitaxel and sirolimus, if the patient keeps coming back with restenosis, and if the mechanical issue has been adequately addressed, and if there are no options available to open the native vessel, then I would go for a stent. So I'll just give you my brief algorithm for SVG stenosis. So if you have an SVG stenosis, you should ask yourself a question. Is it focal stenosis in a healthy looking vein graft? If the answer is no, please ignore the vein graft and treat the native vessel. If the answer is yes, then go for an angioplasty with a drug-eluting stent. Now, if the patient comes back with a restenosis, then again ask yourself a question, is there a chance of treating the native vessel? If the answer is yes, you please go for that. If the answer is no, then do an intravascular imaging, could be IVUS or could be OCT, and then optimize the stent and then do a DCB. If patient has more stenosis in the future again, then either try a different DCB or go for a stent. This is my algorithm. Thank you. So my management option for this patient is treat the native vessel first as a first option. Second option is a DCB, and final option is a drug-eluting stent. Thank you. I'm open for any questions.
Do we keep questions in the end of the both the talks?
Yeah, yes, at the end of both the talks, yes.
Right. Yes. So Dr. Amol, if you want to have some comment?
No, I think we'll have a discussion after both the talks.
Right. So Professor Mohit Gupta, it's your turn to talk about this case. What would you like to have, please? Professor Gupta, you need to unmute yourself.
Thank you, Dr. Kamal and Cadecon team for a great opportunity, and thank you, Sandeep, for a terrific talk. Had I been given the same topic that you have been given, I would have been presented the same way. And I'll tell you there is a reason for this. Why? Because when nothing is sure, everything is possible. And today we work only on evidences. And definitely this is one of the conditions that intervention cardiologist is always in a dilemma. What do? You are fighting like between a David and a Goliath, and guidelines are not there to guide you. So having this thing in my mind, this is the problem statement that you have very nicely given. An elderly male, territory viable. I'm not going to go further into the detail. One thing is sure, we have to intervene. I totally resonate with you that if I am given an opportunity, I will always go for a native artery. There is no doubt about it. There is nothing better than that. But what happens when I don't have an option? Then you have to really understand that you are driving on a rough terrain. This is a very terrible terrain to drive on, and you really have to be very sharp, equipped when there is no evidence, and you have to come out with an ideas, and you have to come out with different opportunities and your own mechanism. And that is what I am going to show you today. So let us understand, what are we intervening in? We are intervening in an SVG, different from a native coronary artery. Three things one should remember always: high atherosclerosis, very, very high inflammation, and almost 10 times higher chance of a thrombosis. This is what defines SVG. And why? Because the lesions here are more fibrotic because of SMC proliferation, and they are very less calcific. Remember, SVG does not has a media which is normal. It is a much thinner media. And I totally resonate with Sandeep when he says that it is more susceptible to mechanical damage by stents and balloons, as is very nicely shown by the imaging. And when you employ a drug-eluting stent, delayed healing, less endothelization, and more uncovered strut, again, which was very beautifully shown by Sandeep. But does that answer a question? No. This is how SVG is working. Endothelial damage to a vein graft, abnormal vein patterns. Remember, a simple vein is exposed to an arterial abnormal pressure. It leads to blood stasis, significant thrombosis. The first thing, it thromboses very fast. And then the process of neoatherosclerosis, more diffuse, concentric, and less calcification, again superimposed with more and more thrombosis. Look at this, more and more thrombosis. And then coupling that, vein graft does not have a muscular rear. So high arterial pressure leads to abnormal dilatation, luminal dilatation, and more neointermental hypoplasia and no remodeling. So what happens? The graft fails. The restenosis is very high, as was shown. Almost 15 to 20%, they are failing within a year, and 50% by 10 years. And our patient, which we are discussing, is falling in this substrate. Beyond 1 year, progressive atherosclerosis and progressive thrombosis. So what is the evidence? Let us talk about evidence and let us design our own strategy. What Sandeep shows, I almost resonate that. The fact file talking about the native SVG vessels won't help. We are talking about the restenosis in a SVG. Remember, restenosis is an SVG, not a native vessel. But what we have to corroborate and correlate the findings and evidence what we have for a native SVG. BMS is better than POVA. There is no doubt about this. Absolutely confirmed. So no question and no discussions about it. But when we talk about a BMS versus a DES in an SVG, the evidence is contradictory, and my friend Sandeep would definitely agree with me. Why? Because the ESAR CABG trial, which was one of the initial trials, very big trial, showed initially within 1 year, the drug-eluting stents were superior. But when these results were published over 5 years, there was a significant late catch-up after 1 year, and the TLR rates in both the groups were practically similar. So, different trials of BMS and DES have shown contrasting results. Basket Savage showing that DES are behaving better, whereas the DIVA trial, a large trial, showing that DES is not doing better than a BMS in native SVG only. Remember, native SVG only. So, the meta-analysis summarized. Look at the contradiction that they are given. The first meta-analysis published by Patel and Deepak Bhatt, they showed that there is no significant difference in DES and BMS for mortality and all the events. Whereas another meta-analysis showed that DES in SVG is associated with a shorter, lower MACE. But these differences are lost on follow-up. So we are really lost. And drug-coating balloon is really exciting, But are we satisfied with the evidence and the guidelines that Sandeep showed very nicely? And I resonate with that. The drug-coating balloons are working superior, beautifully in a native vessel. Is it enough? Let us see. Drug-coating balloon avoids an in-stent approach. Very good. Perfect. I'm happy with that. Paclitaxel drug-coating balloon is established, no doubt about it. But remember, in ISR, in only native coronaries. What about the therapeutic benefit of ISR in SVG? It is unclear. And I'll show you the evidence. Look at this trial. The only trial and evidence that is available till date. The SVG, which is a large trial, it showed that 25 SVGs which had in-stent restenosis. 7 in-stent restenosis in a bare metal stent, and 18 in-stent restenosis in a drug-eluting stent. They were all treated keeping the same hypothesis that DCB will be better. And when on median follow-up of 12 months, they examined the binary restenosis as well as the TLR. What was the result? It was eye-opening. The TLR was 72% when DCB was used in drug-eluting stents. When the DCB was used in bare metal stents, the TLR was only 14%. So 70% chances of high restenosis and DCB failure when a stenosis is occurring in a DES which is deployed in a SVG. Are you happy with it? I am not going to buy it in this condition. But it was only 14% when a DCB is being used in a BMS. What are the reasons? They are not clear, probably different vessel architecture, different wall architecture, other mechanisms. So what are the current options? Current options is native artery. I am totally for it. Redo CABG, not a question in this perspective because our patient is a perfect case of a PCI. Should we use a POBA or DEB? DEB is a good choice, but it is marred with a high restenosis. Almost 70% restenosis with the only evidence that we have. And that is very convincing. And if we use a DES, again, this is also not a very comfortable, but very high peri-procedural events, undeployed struts, multiple problems are there. So how would I define my strategy in this particular condition? How would I resonate with this particular strategy in this particular condition? My strategy would be very, very simple. SVG restenosis, if the ISR is occurring in a BMS, use a DEB. Why? Because it avoids the extra metal, and we have a reasonable evidence to show that restenosis will be less when you are using a DEB in a ISR in a BMS. I am totally with Sandeep on that. But if the ISR is occurring in DES, imaging has to be used preferably in all the cases. Absolutely.
Hello. Sir, time is up.
Yeah, absolutely with 100. But DES is a better choice when ISR is occurring in a DES, and DEB in ISR and DES is shown to have a very high restenosis. So my message to you is all modalities should be used wisely with a clinical experience. Why? Because a fool with a tool is still a fool. So I'm open to any discussion and questions.